Hello, and welcome to today's webcast, Cardiovascular Disease and Psoriasis. My name is Bev Bromfield, and I'll be your moderator for today's presentation. Before we begin, I need to reach out to Dr. Weinberg and ask if you could log in using the link that I just sent you by email. Thank you. Before we begin, I'd like to acknowledge our sponsors, Amgen and Lilly, for their support of the cardiovascular and psoriasis disease webcast. Look for additional webinars in this related health conditions series, which will occur throughout the rest of 2019. We've taken a screenshot of the attendee interface. You should see something that looks like this on your computer desktop in the upper right corner. You've joined this presentation using your computer's speaker system by default. This means if you hear music through your computer, you should be able to hear the presentation. If you prefer to join over the telephone, select Use Telephone in the audio pane and the dial-in information will be displayed. You'll have an opportunity to submit questions to today's presenter by typing into the questions pane on the control panel. We'll collect these and address as many as possible during Dr. Weinberg's Q&A session today. Since some of you may be new to the foundation, here's a little background about who we are, our mission, and what we do. On July 1st, the National Psoriasis Foundation recently launched a new strategic plan which guides everything we do as an organization. To achieve our mission, the following goals were identified. Lead collaborative and transformational research in psoriatic disease, improve health outcomes by increasing the lifespan and health of individuals living with psoriatic disease, secure resources necessary to achieve our mission-related goals. By attending today's program, you've already taken a step towards expanding your knowledge about psoriasis and psoriatic arthritis, moving towards a better understanding of what it means to live with psoriatic disease. If you have psoriatic disease, you can help accelerate our efforts towards collaborative and transformational research that leads to a greater understanding of the disease and a cure by participating in the NPF Corona National Psoriasis Patient Registry, which is the largest independent observational registry of psoriasis patients in the U.S. This registry represents a network of dermatology clinics that collect and study patient health information, allowing researchers to compare the safety and efficacy of psoriasis treatments, better understand conditions that are related to psoriasis, and explore the history of the disease. You can share your experience with researchers about what it means to live with psoriasis and psoriatic arthritis by participating. Hello?
Hey, it's Dr. Weinberg.
Oh, great. Thank you. We'll be ready in just a minute. Thanks. You can share your experience with researchers about what it means to live with psoriasis and psoriatic arthritis by participating in Citizen Scientists. Answer questions and view your data along with over 4,000 Data is used to help researchers gain a better understanding of the disease. To learn more and participate, visit the websites listed on the screen. We continue to improve the health of individuals living with psoriatic disease through our Patient Navigation Center, the world's first personalized support center for people impacted by psoriatic disease. The Foundation's Patient Navigation Center is available to help you find physicians, treatment information, navigate insurance issues, and access support through our one-to-one program and more. Contact us at 1-800-723-9166 option 1 or visit psoriasis.org/navigation center. To help the Foundation achieve its goals as mentioned, please support our mission through donations or by participating in local Team NPF events near you. You can learn more at psoriasis.org/donate or teamnpf.org. On behalf of the National Psoriasis Foundation, thank you for attending today's webinar. Well, you'll learn more about the overall purpose of the AAD-NPF comorbidities guidelines and what the guidelines mean to you as a patient, the prevalence, risk, and inflammatory relationship between cardiovascular disease, psoriasis, and psoriatic arthritis, treatment options and lifestyle changes that reduce the impact of psoriatic and cardiovascular disease on overall health, resources to help gain a better understanding of psoriatic disease, and available treatment options. Now I'd like to introduce you to our speaker, Dr. Jeffrey Weinberg. Dr. Weinberg is a dermatologist in practice with Infinity Dermatology in New York City, which is a network of dermatology clinics offering comprehensive care for people with psoriasis, rosacea, eczema, skin cancer, and more. Dr. Weinberg is also an associate clinical professor of dermatology with Icahn School of Medicine at Mount Sinai in New York. Dr. Weinberg's clinical interests include psoriasis, eczema, dermatologic surgery, and infectious diseases of the skin. He also conducts research related to a variety of dermatology-related topics, including being principal or co-investigator for several clinical trials. In fact, in 2016, Dr. Weinberg received a presidential citation for his work in psoriasis research from the American Academy of Dermatology. Dr. Weinberg is a member of the National Psoriasis Foundation's Medical Board, where he also serves as a President's Council member, which is an elite group of healthcare providers committed to the mission of the foundation in finding a cure for psoriasis. It is my honor to welcome Dr. Weinberg as today's webinar speaker.
Thank you very much. And Bev, before we start, I was able to log in as an observer on my iPad, and I had been unable to log in on the computer to actually move the slides. So should I just ask to have the slides moved?
That works for me.
Okay, perfect. Well, thank you so much, and I'm glad to be able to talk to you today. And let me give you my disclosures first. Research grants from AbbVie, Eli Lilly and Company, Novartis Pharmaceuticals, Sun, and UCB. And Speakers Bureau for AbbVie, Amgen, Eli Lilly and Company, Novartis Pharmaceuticals, and Sun Pharma. Next slide. And we're going to touch on this a little bit later, but right now, what's been going on is that the American Academy of Dermatology and the National Psoriasis Foundation have been developing treatment guidelines, and some of these focus on use of biologics have been released so far. Psoriasis in terms of its comorbidities, and these have been very important for both physicians and patients, and they're also important for managed care to help talk about appropriate use of treatments in the field, looking at the comorbidities associated with this. So again, one of them is care and management of comorbid concurrent conditions to psoriatic disease. These include mental health, psychosocial wellness, and quality of life, care for the management and treatment of psoriasis with biologics, evidence monitoring, adverse events, recommendations for use, and care for the management of treatment of psoriasis with phototherapy. And again, looking at some of these other issues. And some of the ones that will be coming out soon, be released in the Journal American Academy of Dermatology, are treatment of pediatric patients, topical therapy, and non-biologic systemic agents. Next slide. So what do these guidelines mean? And why are they important? They provide guidelines based on current evidence, identifies guidelines for special circumstances, defines the role of the dermatologist, explaining risk for concurrent health conditions, emphasizes the value of education, and promotes shared decision-making between your healthcare provider and you, the patient. Next slide. So let me start out by talking about the evolution that I have seen in psoriasis over the past 20 years. When I was a resident, the systemic medications that we had were methotrexate, cyclosporin, and etretinate, a retinoid. So basically, we had drugs that are commonly used in oncology and transplant rejection. Now, since that time, what we've seen is an evolution and a revolution in this field. We've seen the development of targeted therapies, which have become more and more targeted to the point that they're highly effective. They don't cause end organ damage, and they're really safe for long-term use. And they really change the lives of people with psoriasis. So the treatment has changed, but so has the perception of what this disease is. So initially, in times past, we would have looked at this disease as a skin disease. And now we start to understand that this is not just a skin disease, but it is a skin disease with associated comorbidities. And these are conditions that occur with a primary condition. So we look at it not as a skin disease, but as a systemic inflammatory condition. All right. And when we look at it, we're looking at the whole person, their whole health. And as dermatology professionals, what we have to look at now is not just taking care of clearing the skin, but we need to advise people and talk to them about their health in general, because we know that psoriasis has implications for health. Now, the primary comorbidity that we talk about with psoriasis is psoriatic arthritis, okay? But starting, again, about in the last 10 to 20 years, a lot of information has come out about other comorbidities, including metabolic syndrome, cardiovascular, inflammatory bowel disease, and again, this series of programs will delve in to a lot of those issues. And I'm going to give a shout out to Dr. Joel Gelfand, and I'm going to use some of his slides later from a presentation, who really was sort of the pioneer of this field of really defining the impact, especially in cardiovascular disease. And, and we'll talk about, how this impacts treatment considerations and in terms of how we counsel patients. So today, the talk we're going to talk on today is, again, cardiovascular disease and psoriasis. And, I always make it clear, and it's very important that when I'm a clinician and I'm talking to patients, I'm not looking to scare people. You don't want to see somebody and say, by the way, you have psoriasis, and by the way, you're at risk for heart disease. That's not a good way to start a conversation. But what we want to do is we want to say, psoriasis and the risk factors for heart disease are tied together. And what we can do is we can take them as a package and we can address them concurrently and lower risk for both problems. And we have multiple ways we can address that. So psoriasis is a systemic disease with multiple cardiovascular and metabolic comorbidities. Patients with moderate to severe psoriasis have a reduced life expectancy of 4 to 5 years because of cardiovascular disease. There's an increased prevalence of traditional cardiovascular risk factors: hypertension, cigarette smoking, dyslipidemia, diabetes, and obesity. So what this means also is it's not just the psoriasis, but it's other risk factors which go along with people who have psoriasis. And again, these sort of share a common inflammatory pathway. So, for example, obesity is one of those issues, and it's always been the chicken and the egg. Are people heavy? When they're heavier, do they have more psoriasis? Yes. When they have psoriasis, do they tend to be heavier because of a impacted lifestyle? Yes. So there's a series of interactions going both ways here. Alcohol misuse and depression are also increased and may contribute to excess cardiovascular disease mortality. And systemic inflammation plays a role in the development of cardiovascular disease as well as other diseases such as rheumatoid arthritis. Screening for cardiovascular risk factors is recommended, and we're going to discuss later on, what we do and the recommendations we make for appropriate counseling and follow-up. Next slide. So as I mentioned before, in terms of looking at the science of it, there are common inflammatory pathways in psoriasis and atherosclerosis. And atherosclerosis is when you have the accumulation of plaque, and what we're looking on the left side is a psoriatic plaque of the skin, and what we're looking on is an atherosclerotic plaque in the coronary artery next to it. So the inflammatory infiltrates show marked similarities. The cytokines, the chemicals that are made by the inflammatory cells, TNF-alpha, interferon gamma, interleukin 6, 17, and 8, are involved in both. And again, these are some of the targets now that we look at to treat psoriasis. So they're involved there also. There's extravasation of white blood cells through the endothelium, through the surface of the tissue. And there's Th1, Th17, and T regulatory cells involved. And, this is why, again, we think that if we look at a disease as a systemic inflammatory condition, that if we're treating one part of the inflammation of the skin, there may be benefits elsewhere, and we're going to talk about that in the program today. Next slide. So this was when I touched on the guidelines, this is the joint AAD-NPF guidelines of care for the management and treatment of psoriasis with awareness and attention to comorbidities. So this was published in April 2019. And it was a very good review, again, for clinicians and the scientific community to really put all this information in one place and to make recommendations about not only how can we address psoriasis, but how can we address the other conditions that tend to travel with it. Next slide. And this was a slide from there, but it was reprinted from earlier literature. And this is the relative risk of myocardial infarction with age for psoriasis patients. And this is from one of the original papers by Joel Gelfand. And we look at patients here who have severe psoriasis in the black dots and mild psoriasis in the white dots. And so what does this talk about? This talks about relative risk. So if your relative risk is above 1, it means you have a higher chance of having a myocardial infarction or heart attack. Okay, and you can see here that the relative risk, and we're going to go through some of this data more later, but this is just an introduction, even in younger patients, and again, your relative risk would be much higher in a younger patient because younger patients don't generally have myocardial infarction. So you'll see more of a spread there. But you can see, again, with severe psoriasis, but even with mild psoriasis. So we tend to look at people and say, you know what, if you have greater than 10% of your body surface that's affected by psoriasis, you are at increased risk for cardiovascular disease. All right? And we're going to talk more about this later. But this is just sort of the top level stuff that's showing no matter what your age is, no matter mild or severe, there is risk. Next slide. And again, when we look at the risk ratio here, and this is from a paper by Armstrong et al., the Journal American Heart Association. So looking at the risk ratio, and again, if you're over 1, that means it's increased. So the risk of major adverse cardiovascular events is higher for patients with severe psoriasis. So cardiovascular death, 1.03, so slightly elevated for mild psoriasis, 1.39 for severe psoriasis. Myocardial infarction, 1.29 for mild psoriasis, 1.70 for severe psoriasis. And stroke, 1.12 for mild psoriasis, 1.56 for severe psoriasis. So looking at these, it tells you when you look at these different issues here, there are increases, again, in both groups, but certainly more marked increase for severe psoriasis. And again, if you're over 1, and there you can see here, there are different ranges for this, but if you're over 1, it says there's increased risk. If you're below 1, it means there's less risk. Next slide. So looking at this, the data that they looked at from the Armstrong and some of the other sources that were used for psoriasis and cardiovascular disease, psoriasis is associated with increased risk of major cardiovascular events. They estimate in excess of 11,500 major adverse cardiovascular events in the United States each year. Chronic and uncontrolled inflammation from psoriatic disease may be related to endothelial dysfunction that increases cardiovascular risk, and the endothelial is, again, that's the inside of the coronary artery. And systemic therapies for psoriasis, methotrexate and TNF inhibitors have been associated with reductions in cardiovascular events. And we're going to talk about some of that data later on. And, similarly, where, I just want to make clear my philosophy, and philosophy number 1 is explain the risk. We don't want to, there's nothing that it needs to be frightening about this, just in terms of education. It's in terms of there are many things that we can do about it. Similarly, people say, well, Dr. Weinberg, do you recommend that somebody goes on one of these drugs because it'll reduce their risk of cardiovascular events? Do you think they must go on it? And the answer is no. I mean, no one has proven that going on a drug versus weight loss, exercise, statins, we don't know, all of those factors. So I can't tell somebody that, this is you have to go on this. It's what you must do, but it is certainly an option. Some of the data is very intriguing, and I think it needs to go into consideration when people are looking at what their options are. And there's been, even now, past this, some other data that just came out recently that showed, even IL-12, 23 drugs, in addition to TNF drugs, reducing cardiovascular events as well. Next slide. So again, I want to give credit to Dr. Gelfand for some of the next few slides. You're just looking at an experimental model of psoriasis and comorbidities, looking at environmental risk, smoking and obesity, genes associated with psoriasis, diabetes, and cardiovascular disease, mediating factors in terms of Th1 and IL-17 inflammation, which can lead to atherosclerosis, thrombosis, and lipid metabolism, epidermal proliferation, angiogenesis, treatment. Some drugs such as cyclosporin and acitretin can increase cardiovascular risk. Some, such as methotrexate and TNF inhibitors, can decrease it. There's psychosocial impact of the disease, which can play into the risk for cardiovascular disease, depression, alcohol and smoking, lower socioeconomic status. And all of these factors go together to potentially increase or decrease the risk of cardiovascular disease. So I think that it's important that, again, we look at this as a sort of multifactorial approach to what we're going to do in terms of increasing those factors which decrease risk, and so increase those factors and decrease the factors that increase risk. Next slide. So this is the risk of cardiometabolic disease and psoriasis, retrospective studies that were looked at. The clinical significance, again, increased risk of MI, stroke, cardiovascular death, and diabetes, 5 years of life lost, the risk of MACE, of major adverse cardiac events similar to that conferred by diabetes. Patients treated for severe psoriasis are 30 times more likely to experience a MACE, an adverse cardiac event attributable to psoriasis, than to develop a melanoma. And we can look here at some in this study that were looked at in the British Journal. MI, the mild disease, 1.05 relative risk. Again, if you're over 1, it's higher, 1.5 severe. Stroke, 1.06 and 1.4, respectively. Cardiovascular death, 1.6. MACE, 1.5. Diabetes, 1.5. And the severe, 1.11. So again, we're accumulating a lot of data here that sort of tends to say the same thing. Next slide, please. And the psoriasis BSA predicts death independent of mortality risk factors. So if you have unadjusted, and you look at here, greater than 10% body surface area, your hazard ratio of death, it's 2. Unadjusted, and you look at either less than 3% or 3 to 10%, no increase there. Age and sex adjusted, again, the lower body surface areas don't have, but again, the higher body surface does. It's fully adjusted, again, same thing, higher risk. So even when you take out other risk factors. So again, this is very compelling data, and that's the number we look at, greater than 10%, starts to increase that risk. Next slide. And again, the BSA affected by psoriasis also predicts diabetes, and a BSA of less than 2% hazard ratio of 1.2. That's 199 extra cases of diabetes per 100,000 people. The BSA of greater than 10%, the hazard ratio is 1.6. This is 625 extra cases of diabetes per 100,000 people per year. For each 10% in BSA above 10%, there is a 20% increase in risk. 125, 650 new cases of DM each year worldwide attributable to psoriasis. And we now obviously know diabetes is a risk factor for cardiovascular disease as well. Next slide. And there have also been studies looking at arterial stiffness in psoriasis. Arterial stiffness is an early independent predictor of cardiovascular events. And this is a detailed assessment of cardiovascular risk. Okay, and this was done from a large UK biobank population-based study. Next slide. And there have also been some other interesting studies looking at PET CTs demonstrating diffuse vascular inflammation, and coronary CT. It shows increased non-calcified plaque and high-risk plaque burden. So by doing this high sensitivity testing, you can see early development. Next slide. So TNF inhibitors are cardioprotective in rheumatoid arthritis and psoriasis, meta-analyses of observational studies. And if you look here, there are different studies overall looking at cardiovascular events, but, you know, and with very different results, but it looks like these tend to be cardioprotective in these analyses. Next slide. However, biologics fail to achieve significant difference in cardiovascular disease in meta-analysis of psoriasis randomized controlled trials. All right, so different analyses, different findings. Next slide. So the question is, should psoriasis be aggressively treated to lower the risk of cardiovascular disease? And the answer is we don't know for certain. And again, the observational data suggests that methotrexate and TNF inhibitors lower the risk of cardiovascular disease, but data do not exist to demonstrate a protective effect of phototherapy, apremilast or Otezla, Stelara, Cosentyx, Taltz, Tremfya on cardiovascular events. So some of the newer drugs, but they're newer, so we have less time to look at them. Next slide. So I want to talk to you about some of the other studies that have been done. There was one study, this is Jason Wu, showed TNF inhibitors for psoriasis associated with the reduced myocardial infarction risk versus topical agents. This is a retrospective cohort study of patients with psoriasis in the Kaiser Permanente Southern California Health Plan. Patients with cardiovascular risk factors at baseline, 61.2 had dyslipidemia, 60% hypertensive, 27% diabetes, 44.2 obese. And they looked at topical as a reference, and then they looked at oral, systemic, or phototherapy, and the hazard risk was 0.54%, and TNF inhibitors, which included Humira, Enbrel, and Remicade, had 0.5. So what they were able to show that there was a reduction. This is a median follow-up of 4.3 years. That the hazard risk was 0.5, so it was reduced from 1 at reference just to topical therapy to 0.5 with TNF inhibitors. So showing a positive effect of TNF inhibitors on these cardiovascular outcomes. Next slide. And this, again, just looking at these here, things that affected it, again, TNF inhibitors, 0.5, the oral agents, phototherapy, 0.4, hazard risk, topical agents with a reference that we used, female sex was protective, age less than 65 was protective, having psoriatic arthritis increased the risk, the hazard risk was 1.63, having diabetes increased 2.23, dyslipidemia increased, the hazard ratio was 6.05, hypertension 6.58, the use of beta blockers 1.09, and the use of statins 0.31. So, you know, being on statins was protective, lower age, female sex, and treatment of psoriasis were protective. So this is a very nicely done study showing, again, we see what makes heart disease better, we see what makes it worse. So again, we should try to lower the risks and increase the benefits that we can use. Next slide. And this is, again, looking at time on, you know, so the hazard ratio in 1 year on a TNF inhibitor reduced, it was a reduction of 21.3%, 2 years, 38%, and 3 years, 51.2%. So there does seem to be, again, some cumulative protection of being on a TNF inhibitor. Next slide. This is another study, a Danish real-world cohort study of cardiovascular event rates in severe psoriasis. It was a retrospective longitudinal cohort study from 2007 to 2009 with a mean follow-up of 18 months. Reduced cardiovascular event rates were seen with biologics and methotrexate versus other anti-psoriatic therapies. When they looked at the primary endpoint, death, MI, the incident rates, and the hazard ratio, you can see here that again, the hazard ratio was 0.2, so it was reduced about 80% versus reference for biologics. 0.57 for methotrexate, so reduced nearly by a half. Secondary endpoints, cardiovascular disease, MI, and stroke, again, also reduced with biologics and methotrexate. So again, it's nice to see confirmatory information. Next slide. And again, just to just to talk about other therapies that we're not talking about here, it's not to say that those therapies will not have a similar impact. The other therapies are newer, so these studies have not been done. So I just want to make that very clear. Clinical care recommendations, and again, we'll talk more about this. Educate and screen for cardiovascular risk factors. As dermatology, healthcare professionals, our goal, I mean, obviously I'm not going to be treating people with statins and, blood pressure medications, but my role is to educate them and tell them of the importance for appropriate follow-up and who they should be seeing. Next slide. So National Psoriasis Foundation guidelines can screen for cardiovascular risk factors. All patients with psoriasis should be assessed for cardiovascular risk, especially those with moderate to severe psoriasis. Per the American Heart Association guidelines, this includes assessing traditional risk factors every 4 to 6 years in patients 20 to 79 years of age. Looking at traditional risk factors such as age, sex, total and HDL cholesterol, systolic BP, use of antihypertensive therapy, diabetes, and current smoking. So as dermatology professionals, your dermatologist should be asking all these questions and making sure that if there's an issue that should be addressed, that again, that the individual winds up in the appropriate hands. Next slide. So again, standard screening recommendations: hypertension, normal is 120/80, age 18 to 39, no risk factors in BP, less than 130/85. You can monitor every 3 to 5 years. Age greater than 40 and those at an increased risk should be seen yearly. Diabetes, patients have fasting plasma glucose, hemoglobin A1C, adults 40 to 70 with BMI greater than 25, and repeat every 3 years. Cardiovascular risk assessment, traditional risk factors every 4 to 6 years in patients 20 to 79. And you want to estimate the 10-year risk in those 40 to 79. And there's a calculator in the American Heart Association site where you can go to do that if you wish. Next slide. So in summary, systemic inflammation is a risk factor for developing cardiovascular disease. Psoriasis is a systemic inflammatory disease. Psoriasis is associated with multiple cardiovascular risk factors, and psoriasis itself may be an independent risk factor for myocardial infarction. And again, with appropriate screening and treatment, we can help to mitigate these factors and hopefully improve outcomes. Next slide. So I hope that everybody has found that educational. I would like to open up for any questions.
Okay, thank you, Dr. Weinberg, for your presentation and providing a great look at the evidence around cardiovascular disease and psoriasis. We do have some questions, and I will start with, can you prevent cardiovascular disease if you already have psoriasis? And if your psoriasis goes into remission, is cardiovascular disease still a threat?
Well, I mean, I think in Western society, cardiovascular risk is always a threat, and certainly you should follow all of the basic healthcare recommendations. All we can speak to is risk. All right, and when people make up insurance tables, and they talk about, again, we talk about risk factors of reduction in. This is in a large population, so for any individual, it's impossible to know, but the sooner that, again, you can mitigate those risk factors, you will be reducing your risk. I mean, look, there are plenty of people who could have body surface area of psoriasis, which is 80%, and never get treatment and live to 90 years old. All right. Now, their risk is higher, but we can't speak to the individual specifically without looking at them. So the answer is do everything you can to balance out the risk. And again, I think with the evidence right now, therapeutic intervention can have a benefit.
Okay, great. Another question, does psoriasis negatively affect peripheral arterial flow?
I mean, in the presence of vascular disease, it can, but in itself, no. But I would want to say that I have not seen any data specifically on that, but I'm sure that with any concurrent arterial disease, it could be a factor.
Okay. And how do you know if psoriatic disease is affecting your heart? Do you only know once you have heart disease?
Well, I mean, you don't. I mean, again, there's no recommendation now for like coronary artery calcium scoring or other issues along those lines. So no individual knows. And again, we talk about individuals with psoriasis that, talk about individuals with Crohn's disease or ulcerative colitis or, rheumatoid arthritis. They could all have risk also. So, what I would say is you see your primary care doctor, you see a cardiologist, and depending on your risk factors, they would determine if they wanted to make an assessment. But right now, a lot of the things we talk about, such as PET scanning or arterial calcium scores, are only done if they're indicated clinically, but not just because you have psoriasis.
Okay. And do you see any drugs in the pipeline that help to reduce general inflammation?
Well, all the drugs that we have right now decrease inflammation. All right, and that's we start to understand the role of inflammation in disease. So this is why, again, I think we've gone from looking at a drug, let's say just for example, a TNF inhibitor as a drug that was scary and had potential side effects now to a drug that's not only beneficial for psoriasis, but maybe beneficial for your whole health. So, yeah, I mean, certainly there is a role for decreasing inflammation. I mean, statins decrease inflammation. Aspirin, when used appropriately, decreases inflammation. And biologics can decrease inflammation. So, I think like all of them do that. The question is the end result that, that they lead to lower heart disease.
Okay. And how do I eliminate and prevent inflammation in my body?
Well, I mean, it's hard to do that. People talk about anti-inflammatory diets and such. I mean, you can only control what you can control, and so I think that I mean certainly appropriate nutrition can help. Make sure you have a balanced diet, and then again, therapeutically, if something's recommended, go on that. But it's very hard to say that sitting at home, you can do A, B, and C to lower your body inflammation. I don't think we have that control right now.
Okay. One of the risk factors you mentioned had to do with alcohol use. So a question comes in, does mild to moderate alcohol use affect psoriasis so much that I should consider not drinking at all?
No, I mean, and I don't think anybody says that. I just know that, it's one of the factors. I mean, again, appropriate alcohol use is positive. I mean, they've shown that, limited intake of red wine or whatever can actually be beneficial. I think it's when it's too much that it's just not good for the overall health and the risk of metabolic syndrome. But it's not necessarily that anybody's shown that, drinking X amount of alcohol could necessarily make your psoriasis worse. But it's just overall health. It's not good. So mild to moderate, we don't tell people not to do that.
Okay. And does the increased risk apply to psoriatic arthritis? I noticed one slide that included psoriatic arthritis. Can you expand on that a little bit more?
Yeah, I mean, yes, any inflammatory condition can be associated with an increased risk, like I said, whether it's psoriatic arthritis, rheumatoid arthritis, any chronic inflammatory issue can do that, and it's by similar mechanisms. So yeah, so having concurrent psoriasis and psoriatic arthritis would be more inflammatory. So yeah.
Okay. And you mentioned something about losing weight earlier. Someone is asking, how does obesity affect psoriasis and ultimately your heart? I know there's research about adipokines.
Yeah, I mean, so fat is very biologically active and produces a lot of inflammatory cytokines. So yes, by reducing that, you're reducing inflammation by getting rid of that. I mean, we know that also physically having a lot of weight causes, the body, rubs against each other, the body folds, and that can do it as well. But part of the theory is that, yes, I mean, the fat is very biologically active. So if you can reduce that, you do yourself a lot of favor. And again, a lot of those cytokines share a common pathway with psoriasis. So it's very important.
Okay, another question has to ask about the different types of psoriasis. Do all types of psoriasis have the same cardiac effect?
Well, I don't know that anybody's really looked at those different issues, and some of them some of the types of psoriasis tend to be more transient. I mean, erythrodermic psoriasis or pustular psoriasis, those are bad for the heart in different ways in terms of high output cardiac failure. And there's inverse psoriasis, which probably is very limited surface area, so probably not as problematic. Guttate psoriasis tends to be more, episodic. So I don't have data on that. And again, I look at it. I look at the prediction of the problem for psoriasis is the more you have for the longer amount of time. So I think that's a good way to look at it. It's time and extent. It's like being in a hot bath. All right. If you're in it for a long time, if you're in the hot tub for a long time, you get hot. No one gets burned by touching the hot tub for 2 minutes and getting right out. So I think or just putting their foot in. It's their whole body in for a long period of time that they may have consequences. So I'd look at it more like that.
Okay, that's a great answer. All right. This one's kind of in general. And I think there's an assumption with this. Is the same inflammation growing on the outside of my body also growing on the inside as well?
Well, I mean, it's not that there's necessarily, inflammation on the outside of the body. I mean, there is inflammation there. But remember, the inflammatory cells are coming from the inside. I mean, they're coming into the skin from the body. They're coming in from there. So that's where the immune activation is going on. So it's not like it's going from the outside in. It sort of starts on the inside. And that's what you got to think about.
Okay, that's a great way to look at it. One last question. Does dealing with psoriasis with topical medications also mitigate cardiovascular?
Well, usually most of the studies have used that as a reference, so it's hard to say. And usually we're talking about greater than 10% body surface area, which topicals wouldn't be as impactful. So the answer is, if you had 50% of your body you could clear with topicals, would that help out? I mean, my assumption would be there would be some benefit there, but usually that's not what happens. And again, we're not talking about, I know, people listen to information like this and they say, oh, I have 2 spots of psoriasis, I'm going to die now. But that's not the case. I mean, again, you have to really look at it's people who have a certain amount of disease burden. I mean, if you're at 10% and you can treat the psoriasis successfully with topicals, then you're probably okay. I mean, I would still get your regular health checks, but I'm not alarmed by that type of situation.
Okay, and I'll just ask one more question because it alludes to your this response that you had. How often should someone go and see their cardiologist?
Well, it depends what your cardiac. I mean, they talked about there in terms of, how often people should be followed, whether it's every year, every few years. So, again, I don't tell somebody who has bad psoriasis, oh, you got to see a cardiologist every year. I mean, I want them to see the primary care doctor every year. Depends what their risk factors are. If you're 60 years old and you're obese and you have diabetes and you have a lot of psoriasis, I think you should be having frequent follow-up with everybody. All right? If you are 25 years old and have 15% body surface area, which is relatively well controlled with the therapy, then probably you don't need to see a cardiologist every year.
Okay, Great. Well, thank you very much, Dr. Weinberg, for presenting, taking time to answer the questions, and for such an amazing webinar with all the data. That's very helpful to know.
Well, it's my pleasure. It's my pleasure, and I'm really, I think this is important, and I urge everybody to tune into the follow-up webinars that will occur.
Great. Thanks for the plug, Dr. Weinberg. Okay, in addition to today's webinar, podcasts are available through Apple Podcasts, Google Play, Spotify, iHeartRadio, or a feed service of your choice. You can also access podcasts at the website listed here. Upcoming podcasts address depression and anxiety on October 8th, pregnancy and psoriatic disease, and on World Psoriasis Day, the global impact of psoriasis. You can also hear more about related health conditions with podcast number 32 by Dr. Peck from the Texas Dermatology Associates in Dallas. Contact the Patient Navigation Center if you still have questions, would like additional information about treatment options, finding a physician, or having issues with accessing treatments. You can contact them by phone, email, live chat, or Skype. Once you leave today's webinar, you'll receive a survey to provide feedback about the presentation. Tell us what you think. We value and appreciate your comments. I'd like to again extend a sincere thank you to our sponsors, Amgen and Lilly, for their support of this webinar. Please watch for another related health conditions webinar soon. Finally, you can access our webcast archive at psoriasis.org/webcasts. This concludes our presentation today. Thank you for attending.